we wanted to start by saying thank you for resisting until the last session, but I'm not sure I have to do a special thank to one by one. I can go personally to all of you. And well, since we saw yesterday this stage and the opening, the welcoming session, we thought the format that we prepared was very good for this kind of session, but we needed a special technical support to get one piece of paper, because we are used to sit on a table and moderate from there, but that is very nice. So what this is about is the tuberculosis in the context of the COVID-19 pandemic, and we are very lucky to have a very international panel. So this session is on streaming, so we hope there is many people all around connected to the session, so we'll be happy. And I'm sorry, all of you will get a question or will receive a question. So let's start by talking about what is the outline. And the outline is we will do a brief introduction of the panelists that are already sitting here, and as mentioned, they are from different places of the world. Then we go to the bad news first, but we aim to be very optimistic today, so very short on the bad news and then what we can do to make it better. And then the next one is that all these challenges we suffered in the world of tuberculosis during the COVID pandemic, we want to turn it into opportunities. And for each of the opportunities, we have selected 6 opportunities that we saw that could be discussed. We will ask to one of these nice panelists. You look very nicely colorful. Huh? It is really reflecting the multidisciplinarity of all. And then we will ask more questions. And since we are within a family, we can ask much more. And then about some discussion on this, and what's next, we'll see. Depends how it all ends. So let's start by introducing ourselves. So my co-chair is next to me, is José Domínguez. He's a senior researcher in the Germans Trias i Pujol Research Institute in Badalona. And maybe you'd like to say something else about yourself?
Well, only mention that I am coordinator of the Innova4TV. That is one of the core consortium that is promoting this session. It's a Marie Curie action, in fact, that is based in research and exchange of staff. And well, very happy to be here today with these very good and very nice panelists. And I hope that we enjoy a lot in the discussion. I want also to introduce the other co-chair of the session, that is Christina Prat-Aymeric. She is a clinical microbiologist. She's head of section in the microbiology department in Hospital Germans Trias i Pujol in Badalona, in Spain, Barcelona. And she's also working in the Utrecht, UMC Utrecht. And maybe you can say something more about you.
Finalize. So since 4 years, I'm working here in Utrecht in the Netherlands because I heard it's the more sustainable city. Now, because of several reasons, and I work in the Department of Epidemiology of Infectious Diseases in the UMC Utrecht. This is a very nice hospital. And I'm lucky enough to have all these friends, some from more than 20 years, and some from a little bit less time, but we are all very happy to have you all together. So then we introduce the panelists, and maybe we also ask each of you to say something more. So the first panelist is Zorica Nanovic, and she's a specialist in internal medicine, and she comes from North Macedonia. Maybe you want to say something else about you, or we wait until later? Okay, but we... okay, let's continue. Then...
the next one is Helen Savage. She's a specialist in infectious disease. She now is currently doing her PhD in Liverpool School of Tropical Medicine. I don't know, Helen, do you want to add something to this profile?
No, I think that sums it up for now. Thank you for inviting me today, though. Really excited to have a discussion about the opportunities that we have from the COVID pandemic.
Okay, very nice. The following one is Sadiq Abdurrahman. He's the director of the National Program of Public Health in the territory of federal territory of Abuja in Nigeria. Sadiq, I don't know if you want to add something to this at the moment.
Yeah, thank you very much for the opportunity, and thank you, audience, for having me. This is a rare opportunity for me to come to such an important conference in Europe to share my experiences with the colleagues. Thank you.
Okay, thank you.
Thank you. The next one is Lorenzo Guglielmetti.
Yeah, Lorenzo Guglielmetti, hello. He's a specialist also in clinical infection, and he's working in the National Reference of Mycobacteriology in Paris, linked with the University of the Sorbonne, and he is also working, he's member of the team of the Médecins Sans Frontières. I don't know, do you want to add something, Lorenzo?
Looking forward to this session with an intimate group, and I think we will have a very nice time together.
Okay.
Then we have Nancy Sandoval. She came all the way from Guatemala, and she's an infectious disease specialist in the Hospital Roosevelt in the city of Guatemala, but she has also very important roles in Central America and the Caribbean, and I'm sure many people, it's streaming, I don't know what time is now in Guatemala, maybe a bit early, but we'll try. Maybe, Nancy, you want to add something?
Hello.
Yeah.
I'm so glad to be here, and thanks to Jose, Cristina, and Alicia, and the team ICOS for this opportunity. And, well, let's see.
So welcome also. And finally, Alicia Lacoma, she's a biotechnologist with a PhD in microbiology, and she's one of the really guilties of this session on this connection we are making, because she's the chair of the Coast Advance TB Action. And maybe, Alicia, you want to add something, although we will give time later, but just say.
Okay, thank you. So I would like also to be thankful for the opportunity that the Congress has given us to present both of the consortia, the Innova4TB and also the Advanced TB, that I will have the opportunity to later present to the audience on site and also online. And from my side, that would be all. Thank you.
And she was getting some pain in the throat, but it will be just in time for this session. We will make it. So let's start by the first. We wanted to do something very dynamic and to ask things, so maybe we do something anyway. Somebody in the room works in tuberculosis, usually. Just do that thing of standing, then you don't fall asleep. Somebody works on tuberculosis or related diseases? One. Two. Okay, there is somebody. And our plan was also that you talk to the one behind and introduce yourself, but we'll leave this for another time. And well, for the ones that you have any experience, I hope it also that there was somebody following the advice from the president of the European Society of Tropical Medicine to go to a session that is out of the usual expertise, so we could surprise. Maybe there is somebody that did that. So we know that since many years there is this multidisciplinarity in the management of tuberculosis that involves the patient-centered care, then all the different aspects of the social involvement, and of course, constant investment in research and technology. And this was already a plan since already more than 10 years, but because of the pandemic, there has been going back to the ciphers that we had much earlier, and this has been a little bit catastrophic. This is the bad news first, and in the 2020 and 21, there was really a decrease of the notification of cases, but a decrease didn't mean that they didn't exist. It meant that they were not diagnosed, and if they are not diagnosed, they are not treated. So this was a real alarm in the world of the people that we are interested in tuberculosis, and hoping that it could be an alarm for more people. because tuberculosis has been, for many years, the first cause of death from a single infectious disease agent. And in the last 2 years, the first single agent has been COVID-19. But exactly before this session, there was the release of the...
Slides.
Okay, what is the... here. Of the Global Tuberculosis Report. So it came out last week, so just in time for sending the slides of today. And this is a little bit more optimistic because there was much more cases diagnosed, so more cases treated. But please see the ciphers that it's still that more than 10 million people fell ill with tuberculosis in 2022, and 1.3 million died. And there was almost 500,000 of multi-drug resistant cases. But this is the curve. There was this decrease in notification 20 and 21, and now for the year 22, we are going back to the pre-pandemic numbers.
Yeah.
And
yeah, this was a very nice news, in fact, very optimistic. Everybody mentioned that there was the first time since there is a report that it was diagnosed and treated the large number of patients, more than 7.5 cases. This is very important and very difficult to do, in fact, because as you can see in this declaration of logistical duty, in spite, we are still fighting with, against the COVID, and in spite we are not the enough financial support for doing all the tasks that we have to do, and the belief of, the disbelief of many, the TB community, it has been able to diagnose 7.5 new cases, that this is something that we have to be really happy. And in addition, more or less at the same time, it was performed an historical declaration from the union, the national unions, related with TB, and the general idea is that it will make the effort to be able to treat 45 million of people until 2027, including children, people living with HIV, and also provide treatment for the multi-drug resistant TB. If this is true and this happens, and they find the commitment of the countries, this will be a step forward for obtaining the main goals for the NTB. However,
we came here to be optimistic, we said, but we still are very far away to reaching the targets planned years ago for decreasing, because we have to remember that tuberculosis is a curable disease. So it should be feasible, because there is only the need that people has access to diagnostics and to treatments. And of course, in the background is the need of a really useful vaccine, because we are still using the 100-year-old vaccine, although finally there are already 3 or 4, depending on the age, on phase 3 trials. But for being optimistic, we saw this collection of opportunities that we chose, these 6. Okay, here we have. And for each one, we will ask one of the panelists to give a first answer, but maybe then we ask to some more to have a more perspective, because we have this transcontinental view. And the first one is about the social and political awareness that we think it was reached. The thing that it was given more value to the diagnostics, the improvements in contact tracing, both at the clinical and the epidemiological level in terms of the microorganism of molecular epidemiology. Then to understand, we think everybody understood, but we'll see the need of well-designed clinical trials. And then this impressive vaccine development, but also with some pros and cons that we will also discuss. And finally, we want to emphasize the power of networks. So let's start by the first opportunity that we asked to Zorica. And please, you can come to here. And sorry. we are really all together, and we can maybe do that Maya thing of the here and now.
Yeah, there are 2 chairs here as well. See if someone feels
Somebody
like
wants
be
to
more
come
involved.
here. Thank you very much.
What's the easy way that we can see you? Can you see us here? So that
Yeah, perfect. Thank you.
No,
I
let's
don't
go.
think.
It's for you. Okay, thank you very much. We will pay some kind of beer later.
Okay.
could you also tell one story? There was a famous minister, Dutch minister, who once came at a 7:30 big party meeting, big Congress meeting, 7:30 in the morning after the big party had its party. There was 2 people in the room, and he said, whatever those people get up for me, I get up for them.
Yeah, of course.
Yeah, I was saying that this is very. Saying this is very often for some stand-up comedians, no? That suddenly they do for 2 people, but they do. So we are doing, why not? So first for Zorica, and the questions that we thought for her, and maybe later you can ask some more. It's how has the COVID-19 pandemic affected the healthcare system in your setting? She's from Macedonia, and later we will ask also to someone else. Then do you consider as a thing that it is now better, that there is more social awareness and political awareness that the infectious diseases exist and that there is this transmissible diseases even by air droplet, and how it impacted to benefit tuberculosis? And it has related some stigma. I mean, the ones that we have been in contact with tuberculosis, we know that people that goes with a mask has been stigmatized. But now there was a moment that we all were with a mask. So did it help in something, or did we learn more things like that it must be important to wash your hands, these kind of things? And finally, if it's true that in your setting it went back to normal. So the word to you.
Thank you, Christina. Thank you, Jose. And finally, the microphone is mine, the stage is mine. I couldn't wait for it. Okay. First of all, good evening to everybody, you, the most persistent today. I would like to thank Advanced TB, Cost Action, as well as this Congress for inviting me here to share my experience during the COVID pandemics with dealing with TB. Before COVID pandemics, we were making in North Macedonia good progress in terms of TB control. By 2015, we have achieved the MDGs, we've implemented DOT strategy, and as well as IGRA for TB infection and molecular tests for diagnosing TB and examining the resistance to anti-tuberculosis drugs. And then what? COVID pandemic happened. The whole public healthcare system, in North Macedonia has to be redirected and repurposed to serve the one and only priority, the COVID pandemics. This is the picture of the institution where I am working. This is the Institute of Lung Diseases and TB, and it is a national reference center for TB in my country. Overnight, this hospital was repurposed and became one big red zone, a COVID center. We have to think quick and to restructure our activity regarding TB to maintain the level of TB control we achieved in the years before COVID pandemics. How we adapted to the new situation. In the first place, our mycobacteriology laboratory continued with diagnostic activities for TB throughout the whole pandemics, and this is the most important fact. On the second place, we set up an improvised polyclinic, a tent, in fact, in front of the main entrance of the institute, out of the red zone. And that was the place where TB outpatients were treated and examined during the pandemics. And finally, those who really needed hospitalization, we referred them to 2 small hospitals in the interior of Macedonia, who were specialized for respiratory diseases as well as TB. Statistical data after finishing COVID pandemics in Macedonia. They show low values for notification rate, for prevalence, incidence, and mortality during the COVID years. But we have to be very careful when we interpret these values, because if we compare these numbers with the numbers from the years previously to COVID pandemics and with the numbers predicted in our national strategy, one can see that we have a reduction of notification rate of 25%. We have doubled the number of MDR cases, and we have an increase in childhood TB. This is more than a signal to be more vigilant and to carefully monitoring these parameters, so we could, in time, take preventive activities, measures, before they get worse. Regarding the political and social awareness of the importance of respiratory transmissible disease, I believe that after COVID-19 pandemics and dealing with this rapidly spreading infection, the general awareness of communicable diseases in society is approaching a higher level. But it is fair to say that the political and social consensus about the infectious diseases and the transmissible respiratory diseases among authorities are still being built. Regarding the stigma associated or related to TB, I can only say that stigma related to TB still exists even among healthcare workers. The fight with this stigma is a constant process, an ongoing process. Regarding the stigma related to COVID-19, I think that the better term to use is not stigma, but denial of existence of the disease and the epidemics, a conspiracy theory, which can describe the mindset of a part of a general population, but also the healthcare workers too. Unfortunately, my experience tells me that this pandemic has not changed people's negative attitude much towards respiratory transmissible diseases. It will be a long and demanding fight to change the way of thinking through education, through health propaganda, and after that with implementing indicators, health indicators, to measure, to evaluate what have we achieved by this type of management. And the last question, which was addressed to me, the national TB strategy in Macedonia is returning to normal in a slow but safe manner. We already notified several TB parameters indicators that will require attention in the next year and in the years to come, and those are children's TB, vaccination, patronage, strengthening of primary healthcare to get involved in TB management, and the need of a national budget for diagnostics, and more important, for active tracing of contacts. At the end, I would like to stress two things. The first and most important lesson learned from COVID-19 pandemics for the future should be pandemics, epidemics, outbreaks, they just happen, they can happen in the future. Accordingly, take-home messages should be: we cannot afford ourselves the luxury to be surprised by the next pandemic. We have to create better surveillance and planning system, better system for communication and preparedness exercise, something that we used to have in Yugoslavia. Another thing, we cannot afford ourselves to neglect the diseases of public interest or other devastating diseases, or diseases burdened with high mortality and morbidity. And this should be an imperative in the future. Thank you very much.
Thank you very much, Zoritza. And as you know, here in the audience, online and on site, the incidence of tuberculosis is very different depending on the region. So I would like to hear from Sadiq your impression about this particular question of the social and political awareness. If you think because of the pandemic, it increased the social and political awareness of tuberculosis as a representative of Africa.
Yeah, thank you very much. Good evening once again. Pre-pandemic COVID-19, in Nigeria, in the context, we have programs which drive the activities around TB. Over the years, these programs have been donor-driven, meaning are being funded by international NGOs and sometimes philanthropists. However, budgetary provision from government has not even met up the required specified recommended amount by the WHO of 15% of the national budget. Mm-hmm. With the coming of the pandemic, although it made also a fragile health system, it came to bring to fore the understanding of the need for government to really provide adequate funding. It also exposed the fragile nature of the pandemic, of the system, health system itself in response to outbreak diseases. Even though in Nigeria specifically, we have so many local outbreak diseases throughout the year. For example, we have Lassa fever, we have monkeypox, we have meningitis. We are in the meningitis belt of the Africa sub-region. And to worsen the situation during the second to third wave of the pandemic, we also had cholera. So this has already given us an opportunity to have what we call Emergency Preparedness and Response Emergency Center, EOC. But this is also being supported by Nigeria Center for Disease Control. So with the coming of pandemic, all these were brought to fore, and government realized there's a need to really support these types of outbreak. Secondly, it also brought out a gap in the needs for resources, particularly human resource, infrastructure, and commodities. Of course, we know Nigeria is also one of the high-burden countries in TB. And before now, we were surviving on Global Fund. We were surviving on support from other agencies like UN agencies, Clinton Health Foundation, and to some extent, because it goes pari passu with TB-HIV Institute of Human Virology to support the context of the TB-HIV component. So with that, it also helped the government to understand that there is a need to improve on the equipments, especially in the area of diagnosis, in the area of contact tracing, in the area of capacity building of the staff. So to me, it has really opened up that understanding for the political leadership.
Okay, so we have a positive message, and I want to say that Sadiq is defending his PhD in Universitat Autònoma de Barcelona, all the way from Nigeria, now that he's doing the European tour. So big applause, because this is the testing. And finally, for the opportunity one, because there are still 5 more, a brief comment from Nancy from the Central American, with all your network in South America. What do you think about this social and political awareness? Did it help a little bit?
Okay, in Guatemala, the pandemic has allowed people to know and be more aware of respiratory symptoms and the importance of consulting a specialty when it is a person with comorbidity or for an age. But the stigma of TB still exists and must be said that it also people wear and must be said that it's also our health system, yes, it has to improve risk and prevention, communication to the possibilities of disease. The gap is still wide, but the challenge is to work in generation to best and better public policies.
Okay, so a little bit the pros and the cons.
Pros and
so
cons.
let's go to the opportunity
Okay.
two.
Yeah, let's go to the second opportunity now. We have defined also some questions for discussing. The first one is related with the rapid diagnostics development for COVID, and if it is impacted in the pipeline for TB. We are also, we want to discuss if it is already applied or it's in the pipeline, as I mentioned before. If we can use these new technologies to improve TB diagnostics, and also what are the challenges for implementing this technology or this high technology in high log burden, low resources settings. Then for discussing about these questions, we want to invite Helen to comment on this, please.
Hi, good evening, everyone. So thanks so much for coming. So for most people, COVID-19 was a pretty terrible time, but if you worked in diagnostics, it was basically like Christmas every day. So in the Liverpool School of Tropical Medicine, we were working with the WHO site for their testing all the new machines, and week by week for COVID-19, we would get a new test, we would get new machines, new portable PCR machines, point-of-care PCR machines, so that we could run tests in hospitals, in car parks. And it actually felt like a really exciting time that lots of people from outside the normal space for infectious diseases had come in and seen that they could apply their technologies to a different context because of the awareness everyone had had of COVID-19. So we took over people's offices and they were stacked high with diagnostics. But I think since the end of COVID-19, all these companies and all these people who have put so much time in are now thinking, what else can we do with these? Where can we use these in a different field? And I'm also on a European tour, so I've come from Paris last week, and it was the TB Union conference. And interestingly, there were so many companies there who we saw who had been developing machines for COVID-19, who are now trying to develop the same machines, looking at how they can be applied for TB. And actually, the really interesting thing is, I think, so we saw the statistics on TB, but most people with TB that you see, those headline figures, the number each year, only around 60% or so of people actually get a TB diagnosis. So now there's amazing short course regimes, there's new treatments, but without the diagnostics, people are not going to be able to access these new treatments, and we won't end this ongoing cycle. And some of that comes to the fact that currently every machine, everything is optimized for use with sputum, and if people can't produce sputum or the sputum isn't getting to the lab, then they're not getting a diagnostic. And I think what COVID really showed us is you can test anything for an infectious disease. So we had the swabs from the back of the nose, the front of the nose, the tongue, saliva. You know, it really opened the field up. And I think that's made people think, oh, maybe we should be doing this for TB. And also, excitingly for TB, I think it's really captured the imagination of some of the big funders, and like Sadiq mentioned, so, you know, the Bill and Melinda Gates Foundation, who, they're all now more interested in opening up these opportunities. But I think the really important thing to actually remember, though, is that most of those diagnostics that got sent to Liverpool, we tried them out in Liverpool. In the UK, we were giving out free tests left, right, and center. But actually, in most countries in the world, those tests were not available. They weren't even if you had the money to buy them, they were not available in those countries. And a lot of this technology that we're seeing, it's about getting it to the right places. So how can we implement this technology in Nigeria, in the clinics where it needs to be, in Guatemala, in places, outside of Europe? And I think that's going to be the biggest challenge. And especially the machines, a lot of them are really exciting, but will they stand up to working in a clinic setting where you're seeing 50, 60 patients a day, the maintenance, the staff to run them, the training. So there's new challenges, but maybe some real positives have come out of COVID-19.
Okay, thank you very much. But in your opinion, which is the barriers that we have to solve for implementing the new technology in these low-income countries? Which is the main barriers?
Sorry.
Main barrier?
The barriers. Which is the main barriers that you have to solve, that you have to overcome for implementing technology, the new technology?
I think a lot of it is those pipelines to being able to actually access. So the technologies don't exist in a vacuum. You then have to work out the supply. So a lot of them run on cartridges. They need consumables. So you need to be able to have those supply chains to get them, and then getting it in the right setting. Is it best in a setting, in a clinic with a doctor? Could it be in a pharmacy when the person comes with a cough? But how do you link people into that care pathway? And it's just about getting the right technology in the right place. So you get a diagnosis of TB, but then you need to know, do you have drug-resistant TB? So, all those different levels. But I think the technology is there, and it is portable, and it's being used on different samples. So there is the potential for it to get there, but it's how it's rolled out and optimized for TB. TB is not as easy to find as COVID-19 was everywhere, but TB is a bit trickier. But I think there have been positives, and we're getting there.
Okay. I want to ask also to Alicia, that you are the chair of the Advanced TB, that is, you have a big picture of the technology that and the groups that are involved in the network. Which is the technologies that people is developing, and which is in your view the future of this field?
Thank you for your question. I think one of the type of samples that Helen already mentioned, that were the non-invasive samples, are one of the ones that are in the first line. Thinking, for example, in the urine, that is a sample that is easy to obtain, and it's also easy to transport. And I think that one of the items related to the sample is how do we need to collect the sample, and how do we need to transport the sample? Because maybe there is any kind of conservative process that needs to be done, because we need to make sure that the sample, when it arrives to the laboratory, it still has, it has been well maintained, so that the test will be working and it will have the expected sensitivity and specificity. And regarding the other kind of sample, even if it's true that sometimes it's not easy to obtain, the sputum, when we want to test whether the mycobacteria is resistant or not resistant, I think we still need to rely on this type of sample.
Yeah. Okay, thank you.
Okay, thank you very much. So we go to the next opportunity. We would like to have also some of your opinions, but maybe we do after opportunity 3 in the middle. We will ask some things, so then we keep you awake, so you don't know who will receive the question. So then it is a surprise. So the next opportunity, it's about the contact tracing and the clinical and molecular epidemiology. So with contact tracing, the people we work in tuberculosis is decades that we are used to the search of contacts when there is an active case. But now, because of COVID-19, everybody was aware that it's what is a transmissible disease, and in this case, they are doublet. There is also an increase in the sexually transmitted disease, and people is also aware of the tracing, but this is a different issue. And we would like to ask, in this case, to Sadiq, the following questions. We have seen a lot of improved contact tracing strategies, like including the use of artificial intelligence in some settings, but when you go back to other settings where the incidence of tuberculosis is much bigger, did we see some improvement in that sense? Then the other thing, it's now we are all familiar with the variants and everything that is provided by the analysis on the whole genome sequencing. So it's a good opportunity to implement better that is accessible for places in the case of tuberculosis, although it is a little bit different, the pathogen, so some things are differently tricky. And is really this feasible in every setting, especially when we talk about low-income settings that are exactly the settings with the higher prevalence? So I give the word to Sadiq. What do you think?
Well, thank you very much. First, to some of us that may not understand what is contact tracing, contact tracing by definition is a process where the cases are detected, assessed, and managed of contact of index cases of diseases, of infectious diseases. Can be TB, can be COVID, can be any of the respiratory diseases, infectious diseases. And in the response to program in TB, contact tracing is key. However, the emphasis is put more before the COVID on the close contacts of index cases of the TB, especially the vulnerables, like the children under 5 who have close contacts of adults with open TB, and those with comorbid conditions. But with coming up of the TB, of the COVID-19 pandemic, it exploded the contact tracing to a level whereby it all-encompassing respiratory diseases. For example, in the response pillar, in our preparedness response, emergency response pillar for the COVID, contact tracing is a standalone activity with a lot of community health workers, individuals, which were trained to follow up the index cases, to follow up the established cases of COVID-19. And it is a skilled process in that case because it involves issue of stigmatization, issue of confidentiality and privacy. Like COVID was looked at as an important disease. In Nigeria, it came from few countries that had the disease, like i.e. China, UK, and so on. And it was looked at as ab initio like a big man disease. So, and we know specifically we are coming through designated international airports. So, but as time goes on, the community transmission began. It did not exonerate whether you are a high status or low status, and people begin to see people dying, big men coming down, poor people coming down. And with that, the issue of contact tracing was taken very seriously. So we made it as an important pillar in the response, where during the debriefing, the contact tracers team lead will collect their data and on daily basis are analyzed and updated to the Emergency Operations Center, alongside other pillars. For example, we have coordination, we have infection prevention control, we have epidemiology and surveillance, we have health and safety and so on, and vaccination lastly, where the COVID-19 vaccine also came on board. The progress for the genomic, yes. Of course, as you may recall, in Nigeria, specifically context, we had four different waves of COVID-19. And between the third and the fourth wave, this was driven by the Omicron variants, Alpha, Delta, and Beta. And with that, the only way it could be understood was through genomic sequencing. But before this, for TB, it was phenotypic type of testing that was done. And now it became glaring for you to map the pattern and to understand the spread of the disease and which of the variant is involved for particular containment and strategies. You require to understand the pattern. So it became necessary also to liaise with centers in Nigeria, for example, like Nigeria Center for Disease Control, and then the Federal Ministry of Health, under which we have some research institutes, like National Medical Research Institute, NIMA, in Lagos, and NCDC have a reference laboratory in Abuja. And the beauty of this COVID-19 drew so much attention politically and got political support. And there was an ad hoc committee, both at the Presidential Committee and the FCT State Committee, which have an independent task, and they were able to mobilize resources and establish a PCR lab to advantage of the infectious disease. As we speak, we don't have IDH yet. It's still in the process, but we were able to acquire the PCR lab by safety level 3 in FCT, which augmented the national PCR lab under the National Nigeria Center for Disease Control. So this, at the end of the fourth wave, at the pandemic, we begin to think, what next? How can we put into use this PCR lab? Because it was, before we acquired that particular infrastructure was housing some diagnostic for TB, which was upgraded. The tests that were conducted basically were sputum microscopy, GeneXpert test, because it was at a lower level. And it wasn't doing culture and so on. The biosafety level was, I think, 1 or 2. So with the coming up of the PCR, we now say, okay, COVID is facing out, what can we use the biosafety, the PCR molecular lab? So we begin to think of the diseases. For example, we need to upgrade to do things around viral load for HIV, all integrated. We need to begin to look at how we can also diagnose Lassa fever. Lassa fever is another endemic seasonal disease. Of course, we had a boat from monkeypox, and so on. So that has opened up that opportunity, again, positive, from the COVID to have a lab that can help in fighting future pandemic. And the
last question you more or less already answered, whether it impacted in the next generation
exactly
tools.
So,
and maybe on this last question, I would like to know some opinion from Helen from the Liverpool School point of view. about the implementing, whether you see it really feasible in every setting, because you have more a map of the situation in different places.
I think it actually can be really exciting, the idea of using next generation sequencing, especially as they're bringing online tools for TB now that don't require you to culture the sample. So if you don't need to get your sample cultured and you can use your next generation sequencing direct from sputum, it means that for those people, it's really hard to culture sputum and it takes a really long time. So people may be months into their treatment before they get a diagnosis and then find out that it's a multi-resistant strain. But actually, if we can do it direct from sputum, that does mean that people can find out maybe in 1 week, 2 weeks that their treatment they're on isn't going to work and hopefully get on that treatment earlier. And I think from COVID, so many people were involved in the genomic sequencing that actually there are quite a lot of laboratories now, I think especially in the African continent, they've got quite big networks. So there's sequencing laboratories in Nigeria, in Cameroon, and South Africa are playing a really big supportive role, and that they've got people who were trained, they have this expertise, and also found that there were people in universities who had this expertise, who can liaise with their national staff and colleagues who maybe never really spoke to each other before, and kind of started these networks. And I think going forwards, the experience from COVID that people had, they're really putting to use, hopefully for TB, for HIV, and that using that sequencing, especially when it might be difficult to culture all the samples to be able to go forward. So it hopefully might take away some of that time and step and enable people to access the new TB regimes as well.
Thank you. And also together with the huge development on the technology that is almost becoming point of care with the many pros and cons. But yeah, thank you very much. So let's go for another opportunity, or you want to ask something to somebody of the audience, or?
Well, we can wait until the end.
Okay, we wait.
So, okay, then move now to the option number 4, that is related with the need of well-designed clinical trials that we have learned during the COVID pandemic, because it was absolutely necessary to create evidence in this issue. Then we have prepared we have defined some questions for discussing. Is the better awareness of the need of implement well-designed clinical trials, any advance on the regulatory aspect to make sure that the clinical trials maybe is safety properly ensured, even if learning by doing, and finally lessons learned for international collaboration. Then we asked to Lorenzo that explained his experience and his point of view. I have to say that Lorenzo is representing a very exciting clinical trial, the NTB, that they presented the results in Paris in the conference, in the Union conference. Maybe you can also discuss something about this. He has a lot of experience in this, and also to discussing this with the media. He appears in TV and radio, everywhere. Then yes, please. The floor is yours.
Panelists are leaving, so I think we have to be really engaging. I would like to start from COVID, really, since that's the idea. Like from the first questions, right? And the first question is about well-designed clinical trials, and I think I wanted to try to answer talking about a specific case, which is the case of hydroxychloroquine. So I don't know anyone in the room thinks that hydroxychloroquine is a good treatment for COVID-19, infection with SARS-CoV-2. No one.
No
okay.
one.
I don't know if there are clinicians in the room. Anyone that used hydroxychloroquine for COVID-19 patients in particular? I'm looking also at the panelists. If you used it, raise your hand. Didn't? Okay, I did. Okay. It's good. Either you didn't or you're shy. So I was working in Italy at the time, in northern Italy during the first wave. We were giving everything to patients. So really, we were desperate. And I think we made a lot of mistakes. And it was not only hydroxychloroquine, but I think we were also misguided. The history of hydroxychloroquine started by a few in vitro studies that show that this drug could work on cells infected with SARS-CoV-2. And then there was a study by a group from southern France, from a well-known guru in microbiology, which supported the evidence or supported the use of hydroxychloroquine. And since people were desperate, it was used a lot for a long time. Some observational studies refused these results, some others confirmed that, but the situation was not clear. And hundreds of clinical trials, really, literally hundreds, were started to test hydroxychloroquine. Very, very small trials which were stopped very early because they didn't have enough inclusion, a lot of waste of energy. And then there was a lot of political hype. So anyone remembers some politicians that were really enthusiastic about hydroxychloroquine? No? Well, the president of the United States really liked this drug. Or the president of France went to visit this famous guru to congratulate him. And then the drug was used so much that there were actually shortages for the use of the drug for rheumatoid arthritis, so for patients who really needed this drug. And then finally there were big clinical trials which shown that hydroxychloroquine didn't do anything. It actually increased the risk of toxicity, increased the length of hospitalization. So, what was the problem? That in this famous study, first study was a study which had a lot of methodological flaws. It was a small sample size. It was stopped after only 6 days of inclusion because apparently there was a great effect. They were not looking at mortality. They were looking at surrogate markers like at clearance of the virus from the secretions, but not at what is clinically important, like death. It was not randomized. Patients who received hydroxychloroquine who died or went to ICU were excluded from the study. So in case I didn't convince you, it was a bad study. And so that's why we need to have studies which are done well. So just calling it trial, this one was called a trial, probably was more an observational, interventional study, but in any case, it was not a well-designed trial. Coming to a well-designed trial, which leads to the second question about regulatory aspects, how we can do better. Anyone knows here the recovery trial? Ever heard about recovery? Someone maybe? So yeah, great, but you're biased. So everyone should know about the recovery trial because this is the trial that has given us all the information about, I maybe exaggerate a little bit, but almost all the evidence that helped us treat well patients with COVID-19. All came from one big trial done in the UK. It's a nationwide trial, so they managed to start the trial from the conception to the inclusion of the first patient in 10 days. And then they included overall right now, across years, almost 50,000 patients. When they discovered that the corticoids were actually saving lives, and they had these great effects in hypoxemic participants, the results were so clear that the interim analysis showed that, and in only 3 hours from the results, that became part of the policy in the UK. So immediately was recommended as a treatment for these patients. So it's very important to have the capacity, so we do not dream to have a study that starts in 10 days and gives, impact the guidelines in 3 hours, but we should aim for something like that also in TB, and we are very, very far away. And also just mentioning, this trial is a very good design. It's a platform trial, so it's a trial that it's embedded in clinical care, and then you can test multiple interventions. So they could test corticoids, they could also test hydroxychloroquine, they could test a lot of antivirals, antiretrovirals, and give a lot of answers in the same study. And when they looked at hydroxychloroquine, they didn't look like in the first French study at 20 patients against 20 patients. They compared 1,500 to 3,000 patients. So this is the kind of evidence that we really need. So in terms of safety, very briefly, randomized trials are needed at the beginning when you have, especially in a disease like COVID-19, a new disease, but also in TB for any new drugs, because you really need to know if the drug is working, first of all. So you'll be comparing the safety, but first of all, you need to know also if the drug should be put forward for future studies, should be given to patients. So that's the first step. Then observational data, like big cohorts, are really needed after that, what we call the phase 4, to look for rare adverse events that can occur. So both are really important. And in terms of international collaboration, I think, yes, for example, this recovery trial was done across one country, also internationally, but mostly in one country, across so many hospitals. And then there was also another trial called Solidarity, which was sponsored by the WHO, which was also a great effort in terms of bringing forward a network. So this is really important. But I think this is something that we know in TB. We can work we know that we need to have big networks, especially for clinical research. But I think that we need other things that we added for COVID-19. First of all, we need funding. So the funding for TB, even today, even with the declarations that we have shown, the UN commitment from a lot of politicians, is still ridiculous compared to the funding that went into COVID-19 care. Then we need political commitment. So we have declarations, but we need more. So for clinical trials, for example, this recovery trial was supported by a letter from the government, multiple letters. They were saying, you have to include the patients here. When I was in Italy, we had some trials, and they were at regional level, not even national. They were regional. Even inside the same region, you have different concurrent trials testing more or less the same thing. And finally, we need equity in networks and in clinical research, because networks in TB, like in COVID, usually are run by the Global North investigators, so people from rich countries and low incidence countries. So we need to involve more people from the Global South in designing the study. Their patients should be more involved in designing the objectives of the study, what are the outcomes which are important, civil society. And then once the trial is done, we need to give access to the treatment, but also to the diagnostics, to the communities that actually contributed to perform the study. And we need to restitute the results to these people. And this is really something that we don't do enough.
Okay. Thank you very much. You can sit if you want. Yeah, now it's clear, if it were not clear enough before, that the clinical trials are key for advancing in research. Okay, there is a question.
Yes, the question. Yeah.
Okay, wait a second, Santi. But after the COVID pandemic, it was clear that it's absolutely necessary to have very good perform clinical trials for creating enough evidence. Talking about clinical trials and clinical trials on TV, Helen, I know that in the Liverpool School Tropical Medicine, they are performing several clinical trials and clinical studies around the world. Then which was the impact of the COVID in the course of these clinical trials, and how they have solved or they have restarted these studies?
So yeah, I think in the UK we had quite a unique situation, which you alluded to, but by having a national health service, it meant that any trial that was to do with COVID, everything got fast-tracked so we could get ethics within weeks, and everything was rolled out so quickly. But interestingly, also, so all research staff, we were all recalled from our jobs and we were put onto COVID-19 trials. So I left TB and moved to COVID-19, diabetes, all the other research stopped and went into COVID-19. And I think that just alludes to how much money and time was thrown at these clinical trials, and we just don't have that in TB. But I think we have really learned from this, and to kind of setting up those global collaborations to start clinical trials in sort of more neglected diseases and TB. So in Liverpool, they're leading a Start for All consortium looking at diagnostics. And this is a platform across, I think, 6 or 7 different partner countries. So everybody is involved in that trial design from the start and having different phases of implementation, kind of taking from the recovery kind of idea of being able to build in new technologies as they come along for diagnostics. So I think we really have learned that kind of we need big trials to get the data we need rather than recruiting small numbers and small places and across lots of different countries, especially for TB, because it's not going to be a one-size-fits-all by just looking at one country. But yeah, I think it's still a big challenge, but we've learned a lot, so fingers crossed.
For sure. Okay, thank you very much. Maybe we can attend now the question from the audience, yes?
I hope this works.
We are, yes.
The back.
With so many people, it's difficult.
Yeah, it's difficult.
It's difficult to see.
Can you, does it work? Yes. So the question is for Lorenzo, and actually I have a friend that he said that there is no bad results in clinical research, but badly designed clinical trials. And the question is for you, you've been talking about COVID, but in the case of TB, how would you define a well-designed clinical trial for COVID, tuberculosis? What is the key things that you need to look at?
Yes. Well, yeah, thank you. I think for me, what defines a good clinical trial in TB is what defines a good clinical trial in any other disease. And I think for me, that's the message mostly, because sometimes we think that since it's a disease with very little investments and neglected disease in a way, even though it's well known, we tend to have lower standards somehow in clinical research. And I think so. In terms of what is a good clinical trial, is a trial that is performed according to the good clinical practices, that has ideally as for sure randomized as a control, if possible, it's either placebo controlled or controlled with the standard of care. If there is a standard of care, this is adapted to the best possible standard of care, so a good control, if possible blinding for investigators and participants. So all these categories, which are what defines a high quality clinical trial. But there are a lot of examples. I just want to use the opportunity to say that in some fields of clinical research in TB where the standards are lower and are considered to be fine, just because there is so little funding, it's so complicated to do it, that in the end it will be better than nothing. And I think we should not accept this, and I think that we need the same good standards that we need for any other disease, also for TB and many other neglected diseases.
But
no, please.
But the question is more, I mean, obviously you need to have the good standards, but the question is more about the actual design, how we focus the question that we want to answer with the trial, because we can conduct a perfectly clinical trial according to a standard, good clinical practices, but still we don't answer the question. So the question is more for you, what is for example, developing new drugs for TB or combinations? What are the key questions that you should be actually addressing and focusing?
Okay, yeah. No, I think just briefly, and maybe I can also open to, I think now the goal in TB treatment is a lot about shortening the treatment, but I just want to say that I think the question should come from patients. And that this never happens. Actually, there have been very interesting presentations from surveys from the WHO that asking at the patients what are the most important outcomes for them. And although all the groups look at treatment shortening as the most important result, this is not always the priority for the patients. Sometimes if they have to choose, they will prefer a bit longer, but no risk of toxicities, which in particular permanent disabilities. They don't want that as a risk. I mean, they don't want it. It's very individual, but many patients would prefer to avoid toxicity rather than having a more effective treatment as soon as it works reasonably well. So I think we as a research community, we should listen more to what actually the community asks from us.
Okay.
Thank you. So we...
Okay, there is one extra question,
sure.
and then we will move to the...
Yeah, I really feel sorry for you, so I can also wait with my... But it is a little bit related to this discussion. I'm Cordelie van Heteren. I work currently for the World Bank India TB program, and I'm a long-standing health and TB and PBF person. I was also in Paris, and very interested in what it demonstrated to me as not a TB expert of the way the field had moved. My question is to what you discuss here about what we saw during COVID, the happy chaos for some that COVID was, and the not so happy chaos for others. And there is, of course, a lot of more fundamental systemic questioning going on, not only in the research space, but in the vaccination space, in the... The last question on this slide here is lessons learned from international collaboration. What I hear very much in a lot of the literature that I read is there was a lot of scrambling for opportunities amongst some, and not necessarily from the perspective of building just and sustainable health systems, like is the key topic in the conversation here in this conference. So in the final rounds, you don't have to answer me now, but I would really like to see if we can be a little bit more honest about, there is no lack of money in health. There's a huge amount of money in health. There's a lot of lack of good governance. There's a lot of lack of, real collaboration. There's a lot of lack of, and everybody who's a little bit older than 20 years knows this. So can we maybe have that conversation as well in the final rounds? Thank you.
Okay, we think to stop the questions because we will need to finish the topics and the opportunities. Maybe we can discuss later, if you don't mind.
Okay, so maybe then we combine, we will do. And the next thing, it's in fact related because it's the huge vaccine, the huge effort for the COVID on the vaccine development. We all witnessed a once-in-a-lifetime thing to have in such a short time a portfolio of vaccines. But for tuberculosis, we're still using the same one of 100 years and with a limited efficacy. Does somebody know any new vaccine of tuberculosis? I think there is somebody there that can know. No? Nobody? Not even the ones from Zaragoza? Okay, so finally we have 4 vaccines in phase 3, and one of them is the MTB-BAC that is from University of Zaragoza, and it's a more than 20 years story to reach that, and it's still, so it's also, now we saw that, of course, the microorganism is a little bit more difficult than coronavirus, but of course, if there is enough investment, it is feasible. But we have Nancy to ask some other issues related to vaccination, and the questions that we prepared is, did it have any impact for the vaccine development of TB, this that we witnessed, or in the awareness of the need of vaccines, or these problems with vaccine hesitancy? We know that, but let's analyze a little bit more. And Nancy is very active in many strategies. You can see her in many social media doing all the strategies for adherence to vaccines and informing the population and the civil society. And this is a huge work that the medical doctors, many times, we are not so used to do. And this is relevant. So I give the word to you, and here is the...
Thanks again. Okay. Allow me to reflect on the last time I attended ECTMIH #Sagobona Barcelona. Yes, Emma. It was in 2022. It has been more than 10 years since I volunteered for the Congress, where I believe I opened my eyes to the global world and how international health would be part of my daily practice. And sometimes I would always work on my space. I appreciate the opportunity. Sagobona Utrecht. Now, before I address my main topic, I want to talk about COVID and vaccine. Let me see. I believe analyzing how COVID was addressed can inform how we should approach the prevention and control of TB. For example, disparity in vaccination rates between high-income countries and low-income countries must also be addressed. Although experts were clear that vaccines were necessary globally for widespread immunity to the virus, we saw unplanned challenges to administering the various injections that we obtained. Geography and income divide the world again. The minimum vaccination percentage among high-income countries, almost all located in Europe, exceeded the maximum recorded by low-income countries, almost all of them in African continent. In early February 2021, only a dozen countries within the low-middle incomes group had vaccinated more than half of their population. Whose goal of vaccinating 70% of the global population by mid-2022 faces delay and was not met until 2 years later. There is a lagging gap between vaccination in affluent nations and those facilitated through the COVAX mechanism that only continue to grow. Still, I believe COVID shows us that we can end pandemic. Yeah. So I take ownership of the well-pointed words that appear in this month's editorial of Lancet Infectious Diseases, highlighting that we need to take a real turn in the prevention and control of TB. If we can accelerate researches, increase support for the end of COVID pandemic, why can't it be done for tuberculosis? We see glimmers of hope in the journey toward combating TB. Late-stage vaccines candidates like ECTMIH2023 showing promise, as well as advancements in therapeutics and diagnosis. Looking ahead, the future Spanish vaccine, MTV-Vax, which although not yet a reality, he just entered phase 3 of efficacy trials. With good diagnosis and treatment of TB, this vaccine could contribute to control. However, these advances encounter challenge due to resistance and various barriers in regulation, funding, and accessibility. It's important to recognize that the components of COVID-19 vaccines hesitance have been studied and analyzed for a better understanding and approach. Essential aspects to consider the growth of the vaccine, rejections, include uncertainty about whether the world arrive, the type or the number of doses recommended, misinformation, and the politicized handling for information. There were also pandemic decisions which are not always based on scientific evidence or for benefit the population's health. This was more noticeable in countries where inequality and inequality were distinctive features. But even this challenge, we know that the trust in the vaccines must be restored because #vaccines work. They have saved many million people from consequence, complications, and death caused by COVID-19. On the topic of acknowledging exceptional advance, I would also like to recognize that Catherine Caricot or Drew Weissman, they awarded the Nobel Prize in Physiology or Medicine in 2023 for the groundbreaking work on RNA basis for the COVID vaccines, a milestone that celebrates 13 women received the Nobel Prize in Medicine. Now, in closing, I want to express my sincere gratitude for your attentive presence here now today. Thank you.
Next, and the last opportunity that is related with the power of networks, that I think it probably is one of the opportunities more related with the topic of this conference, that is people, to make people together and to work together for a global health. Then the questions that we have defined for discussing with Alicia is the world became global, but obviously context still matters. Then are the networks properly addressing the need of interdisciplinarity? The second one is the One Health perspective, human, animal, and environmental, properly integrated? Because we can see that it's absolutely needed to take into account all these elements. And the third one is the social science and the gender equality that is obviously important in general. You are behind me, and it's a bit difficult to speak. And is this well addressed in the networking, in the networks, and what is your opinion?
Okay. I will try to be on time. And to be honest, I think that some questions will be altogether answered in the following slides. So, first of all, I wanted to present a little bit what is the background of these two networks, the Innova4TV and the Advanced TV, and how this story began. So this started back in 2013 with a very small project in comparison in terms of partners. That was the TB prognosis that involved 4 partners from 3 countries, and the project was very specific in terms that the idea was look for biomarkers by metabolomics. We were wondering whether there were serum biomarkers or urine biomarkers that could help somehow in the diagnostic and monitoring treatment. When this TB prognosis ended from the Institut Germans Trias y Pujol, at the second attempt, we were granted the Innova4TV that, as Jose mentioned earlier, it's a RISE project, Marie Curie action. And here we increased the number of countries. We were from 3 to 6 countries, and also the number of partners. Here I forgot to mention that in the first one, the countries were Ukraine, Sweden, and Spain. And for the Innova4TV, we included Moldova, Germany, and Chile in South America, broadening the international vision, because we really think that, as Jose was mentioning, the context matters, and it is not the same problem in all the different countries, as we have seen for the COVID management. And in this Innova4TV was aiming at exchange researchers and clinicians from different settings, the academia, the hospitals, and also the small and medium enterprises, because it is not only the background of the researchers or the investigators, it is also where do they work and what can be their contribution to solving the problem. And just last year, we got granted this COST action. The COST is the Cooperation in Science and Technology, and it's an organization that receives funds from the European Commission. The Advance4TB was granted, as I mentioned, last year, and we have now just accomplished our first year. And now I highlight here that we are not talking about partners, but we are talking about members, because for the advanced TB, it's the individual that contributes to the action. It's not the institution per se. That is why there is this change in the terminology. And now at the moment, we are 134 members from 42 countries and growing, because we are like updating every 3 months the applications of people wanting to participate. And regarding these members and this interdisciplinarity, there is people that has a clinical background. We are talking about pneumologists, radiologists, microbiologists, but there is also people from the academia that are more specialized in product development, for example, in diagnostic evaluation, search for biomarkers by different technological platforms. We have also small and medium enterprise, because we think it's very important to have the industry liaison, because if we want at the end to have a diagnostic test or a monitoring tool, we will need the industry behind to produce these final end user products. This is the current map of where are these members coming from. It is true that there is a panel of colors. This only makes reference because for the cost administration, it is important from which country you are coming. That is why there is these different 4 colors. But what I wanted to show you is how the network has broadened around the world, and now we are having participants not only from Chile, as in the Innova4TB, but we have other areas of the world with representation. But I have to mention that we have also some gray countries. So I invite, if any of the people in the room just want to join our network, in 2 slides, I will show you how you can join, and you can help us to cover the map more colorful. In particular, in this cost action, we have identified 4 working groups. One is more devoted to the clinical cohorts of patients. We would like to be sure that all the clinical sites that are represented have all the capacities for performing clinical trials, such as the ones that Lorenzo presented earlier. We would like also to harmonize how the samples are collected, how they are preserved, in terms of how to develop trials for sensitivity and specificity evaluation. This links perfectly with Working Group 2, that is for the development and evaluation of novel diagnostic methods. And in Working Group 3, we have the design of novel therapeutical strategies. And we have also a working group for dissemination and communication within the network and also outside the network, because we really want to have like an impact at different levels. These are the group of stakeholders that we identified. And this is a representation of where do the members come from. And as I mentioned, there is researchers from hospital, clinics, universities, research institutes, SME, and we have only at the moment only 1 non-governmental organization, but maybe after this, our participation in this Congress, we will have the chance to increase this key role participant. This is the official website from the cost administration, where you can see exactly which are the objectives of our project, and also how you can reach us. And I am also happy to mention that 2 weeks ago, we launched the advanced tb.eu website, where you can follow all our activities. And you can also find information about how to join our network. Regarding the second, because the next slide is just the turning challenge, so I just wait for a moment. When I was mentioning earlier about the interdisciplinarity, there is also veterinarians in the network. And I think that this really connects with the One Health perspective. That was the second point in the Opportunity 6 slide. So we really think that we need to integrate not only the human, that we know for sure that it has an importance, but there is also a TB in animals that needs to be addressed. Maybe not in some parts of Europe, but maybe, yes, it is a problem in Africa, for example, in determined sites. And regarding the third point that was about the social awareness, I agree with, I think it was Zorica that was the first speaker on the floor, about the stigma and how we need to make sure that this stigma, little by little, is reduced. I think that we need to engage as much as we can our municipal, local, and national governments, because we really need to show up and to make clear that even if COVID does not affect in the same, if TB does not affect everybody as it was shown for COVID, in determined places of the world, it's really a problem, and we need to put all our efforts to try to diminish its impact.
Great.
And
Can come back to you.
From my side.
Yes, you can. Thank you very much. We are almost in the time of discount, but we have I want to make a couple of questions before the closing remarks. One is to Alicia also.
Okay.
Yeah. A very nice presentation and very good discussion about the One Health point of view, in fact. But the majority of lessons that we have attended today is related with climate change. Do you think that it's possible to connect the climate change with the tuberculosis also? It could impact also in the managing of the TB?
Okay. So it's just the second day of the Congress, and we are all aware that the climate change is a global health problem, and it will have like a direct or indirect, we still don't know, an impact on how TB can be controlled. There are different factors of the climate change that I think could potentially affect TB. One of them is all this lack of water, all these droughts that are in different parts of the world can for sure have an influence on malnutrition. If there is no possibility to grow aliments, we know that deficiency in some vitamins and some elements hamper how the immune response is able to control the disease. So I think that this would be one example. And then there is another one that is more related maybe with the meteorological changes, but I don't know if the air pollution can also have like an impact on our respiratory system and how we respond to these factors. There is the cigarette smoke that has been for years known that has an impact, but there is also the diesel impact, there is also the plastics that unfortunately there is a session on plastics in the same time that we are having this one, and it has already been shown that plastics can be detected in clinical samples. So we really think that this can have like an impact on how we deal with infections.
Yeah, for sure. And I have a question for Zorica, related with networks. You joined the Advanced TB from the beginning, and I want to know your view from an individual perspective or for an institutional perspective or even for a country perspective, which is the advantage to be involved in this case, TB network, an international network. Yeah, go.
Go.
It's okay. Thank you for the question. I think I could stratify the impact of TB networking in three levels. First level would be making new contacts, meeting new people, colleagues, new institutions, new methods, getting introduced to new methods, approaches. And the second one would be exchange of experience, exchange of knowledge, and building capacity to reach the third level. Third level would be mutual collaboration and making mutual research projects. That I'm not talking only just theory. I could say this before Advanced TB and before Alicia invited me to participate in the project. For 25 years, while I'm working at the Institute of TB in Skopje, there was no research project in TB. In COPD, asthma, deep vein thrombosis, yes, but in TB, not. And after advanced TB came in Macedonia, we have 3 invitations for scientific and research projects in our institute. And this is important for the institution, for the country, for me, of course. But the most important thing is that younger colleagues will be involved in the research project in the future.
Okay, thank you very much. You can see to be involved in networks is good, and you are also invited to participate in Advanced TV. Okay, then during all this hour and a half, we will be discussing about turning challenge into opportunities, and it's time for concluding remarks. Then I will invite to all of you to if possible, to say something for summarizing the topic that you have discussed. And also, in view of increase the interculturability and the diversity, if you could say something in your mother tongue, those of you that have a mother tongue different than English, and to say something in a positive and optimistic view for the future. Then the first one, it will be related with social and political awareness. Then, Soritza, please. Yes.
I will say something in my mother tongue language, Macedonian, and the sentence is: Македония може да я победи туберкулозата.
Okay. And something for summarizing the topic in English about the stigma and about the social awareness.
This is a comprehensive sentence for all of that. It means Macedonia could fight TB.
Okay.
Thank you.
Thank you. Then the second one is the value of diagnostics, the second opportunity. Helen?
Being a British person, I obviously only speak English, and I'm too embarrassed to try and attempt anything in Spanish with all the colleagues around me. So I think COVID really showed us, if you get people from different fields and different worlds and apply it to a health problem like COVID-19, the amount of progress you can make in diagnostics. And if we can take even a small part of that into TB, hopefully we can find those missing millions and get them on treatment and start to find them and solve this problem. So yeah, really positive.
Okay, thank you very much. Then the next one is the contact tracing clinical and molecular epidemiology. Then Sadiq, if you can say something as a concluding remarks and then something in your mother tongue.
Yeah, thank you very much. With the lessons we learned from COVID-19, we came to understand that contact tracing is key to interrupting any infectious disease, particularly like TB. And it is one of the strategies also that the transmission can be nipped at the bud, especially of the close contacts. And if samples are, contacts of the indications are line-listed promptly, and samples are taken and diagnoses are made. If they are negative, they are placed on intermittent preventive therapy, IPT for children and adults, and that can prevent and bring to bear the control of TB globally.
Okay, and now your very nice language, your hope for the future in your mother tongue language.
Sorry?
Could you say something in your language? In your language, your native language.
Okay. Let me get on. Thank you for the opportunity. My friend from Nigeria is right now seated. I'm from Nigeria. He's from Nigeria. Nigeria is a very huge black nation in the world. We have about 6 geopolitical zones with different, almost 200 to 300 dialects. But we have official languages across the regions of the 6 geopolitical regions. In the north, which have the northeast, northwest, north central, north east, we speak Hausa predominantly. And in the southeast, we speak predominantly Igbo. Southwest, Yoruba, Shakiri, Ijo, maybe in the south south-south.
Okay,
so
let's go.
I'm from
Let's go for the sentence.
Let's go for the sentence.
So I'm from the northern region, and we speak Hausa. Hausa is one of the major languages, even spoken internationally. It's used for communication, even in BBC. There's BBC Hausa service. There's Hausa service, France International, German, and so on. So I will say in Hausa, Inayini. Inayininku means good evening. I've said also, Inagaja, how are you doing? So I will speak subsequently in what I'm summarizing in contact tracing in Hausa.
Summarizing.
No.
So, abunda na faɗa a cikin
Sadiq, I think it's enough.
Yeah,
I think it's enough
because
because the time is running.
Look at that.
I'm sorry.
Thank you very much.
Okay, they are asking to close. So maybe just say the sentence in your language.
Yeah.
So Nancy, in
Nancy, you first.
Well, bueno, yo solo quiero decir que hemos tenido mucha información que nos dicen que las vacunas funcionan desde siempre. Entonces, tomemos todo lo que ha hecho COVID, aceleremos y tengamos pronto una vacuna que pueda hacerlo. Entonces, vaccines work, eso.
So vaccines work in a longer sentence.
Long sentence.
Okay.
Alicia in Catalan.
That's a
Sorry.
Go.
I go? Okay. The power of networks, penso que hem de treballar junts, penso que tothom ha de portar el seu granet de sorra i penso que una malaltia com aquesta, que involucra tants factors, tants elements, necessita de la visió de tothom. I per això penso que entre tots, en algun moment hauríem de ser capaços de controlar i erradicar la malaltia.
So it's the power of networks in a longer sentence.
Something happened.
Okay, and about the trials.
Trials. Possiamo fare meglio nella ricerca clinica per la tubercolosi, possiamo essere più veloci, più efficienti e soprattutto molto più equi.
Okay.
Thank
The
you very
clinical trials
much.
in a short language. Yeah. And then close
Okay,
there.
so thank you very much for the ones you were here, for some that are online. Apologies to the technical team that made it longer. It was challenging to do this in this, and hope to see you soon. And sorry for the question. You can do afterwards the question. So thank you very much, and we hope it was an optimistic message.
Thank you very much to all of
Thank
you.
you.